funded through SAMHSA. So we'll quickly do that and then get to the meat of our project here today. The one we're doing today is the impact of racism and bias in the diagnosis and treatment of psychosis. I just want to provide this one disclaimer, which is that the INTAC is financially supported by SAMHSA, the Substance Abuse and Mental Health Services Administrations. However, that does not mean that anything we say today is that which has come from SAMHSA or would be endorsed by them. So these are our own ideas, but do know that SAMHSA has been the primary supporter of the INTAC. Just a quick overview of what the INTAC is. Yeah, we can go on to the next one.
Okay.
The INTAC here is actually run by CARS, the Center for Applied Research Solutions, but there are a number of partners, which include Georgetown Center for Child and Human Development, Change Matrix, the American Academy of Pediatrics, MedStar Georgetown University Hospital, the University of Texas at Austin and their Institute for Excellence in Mental Health, FREDLA, the family-run executive director leadership association, and then Youth Move National. So all of these partners work as a number of teams. There's 6 teams that work for this INTAC for systems of care. And of course, our goal is that all children, youth, young adults, and families with emotional or behavioral health needs can access evidence-based treatment and recovery services in a well-coordinated system of care. And again, we serve pretty much anybody who's going to work within the system of care for child, youth, and families. So that's agency leaders, the mental health workforce at every level, primary care providers, people who work within schools, particularly in the mental health kind of positions, community-based providers, peer supervisors and peer navigators, and family navigators and family partners, as well as youth, which also includes youth partners. And I'll just mention that our services are not, there are no costs associated with our trainings like we're doing today. We do a number of different things. We will do individual consultation to any entity who's seeking specialized kind of assistance. We do a number of other things ranging from podcasts to communities of practice to producing documents, including our little 5 things digest of latest, greatest things that are going on and a variety of things like this. So please don't hesitate to reach out to the INTAC at any time for any particular needs that you might have. Okay, and with that, we'll get to the meat of today's topic. Our presenter today is Dr. Olivia Hamra. She is one of the people who is trained with us at Georgetown here in DC. She is a well-versed and very familiar person with early onset psychosis. She's been part of the consortium that's been looking at that particular issue now for some time. So I will let her tell you anything else about herself that she would like to tell you, and then I'll turn it over to her right now. Thank you, Olivia, for being here today.
Thank you so much, Dr. Bostic, and it is really an honor to be here today. I'm really excited about doing this webinar. So thank you all for being here with me. Just a little bit more, I wanted to kind of disclose about myself in relation to our topic for today, is that I am a white female, and I did grow up with privilege. I did not learn the things that I will be presenting to you today in grade school or undergraduate college or medical school, or even in my adult psychiatry residency training. I'm so thankful now to be in a fellowship program that pushes its trainees to be culturally aware and continually educating themselves about anti-racism and about advocacy in minority populations. So creating this webinar was really, it's a piece of my own education on the history of Black America and how it has influenced our approach to mental health and mental illness today. My hope is that today you will walk away having learned something new, and that I too will have gained more insight and perspective on these issues based on the discussions that we have. That being said, I would love as much participation as possible from everybody here. I know it can be a bit tough on Zoom, but I have set up some polling questions and I've set aside times to share our own reflections and thoughts and ask questions and to really discuss as a group the things that we're presenting today. After this presentation, you should be able to describe 3 historical events that contributed to racial biases in the diagnosis of schizophrenia, 3 characteristics of schizophrenia that distinguish it from other psychotic disorders, 3 components that define clinical high risk for psychosis, 3 ways in which systemic practices maintain racial and cultural biases, and 3 steps you can take to advocate for your community to correct these biases. All right, so starting off with kind of like a word association question to get us all thinking about the topic of race, and also to kind of get us all into the pull everywhere stuff. When you think about race, what comes to mind? If you can see on the top of the screen, if you open a new browser link and go to pollev.com/Olivia Hamra 142, or you can text Olivia Hamra 142 to 37607. You can start to type it. You can type in as many words as you think of. And we can kind of see the associations that people have or the thoughts that people have when they first start to think about race.
Olivia, do you mind just putting the link into the chat box?
Sure, I can do that. Let's see. Okay, and if people type things into the chat, I can add them. Wow. Lots of stuff. I don't know if I can keep up.
Olivia, I can help add it in if you want to,
Awesome.
and also go through it if that helps out.
Yeah, I've definitely fallen way behind. I can't
Sure.
text that fast. So this is like really cool to see. Like discrimination is a big one. People are thinking about power, social superiority, appearance, difference, trauma. So a lot of different things that come to mind. And I'm also seeing people type in like skepticism, pride, self-identified. So we're all kind of like getting in the mindset here. So now kind of building on this, I want to ask this next question. True or false? There are known biological differences between people of different races. Okay. So I'm seeing, I'm looking in the chat. Let's see if people are answering up here. Oh, here we go. Yeah, I'm seeing a lot of falses, a couple not sure's, a true. So this kind of brings us to this question of what is race? And ultimately, race is a social construct and it has no biological basis. This definition is one that I thought was kind of a nice summary, that race is a socially constructed taxonomic stratification of power based on proximity to whiteness, with individuals of African descent being the most distal category, for the purpose of maintaining a culture of white supremacy.
You may think you know exactly what race you are, but how would you prove it if someone disagreed with you? The fact is, even though race drives a lot of social and political outcomes, race isn't real. One of the first people to attempt to categorize humans according to race was a German scientist around 1776. He came up with 5 different groups according to physical appearance and geographic origin of their ancestors. Americans of European descent eagerly bought into this type of thinking around the same time. Some historians have said the idea that there were different races helped them resolve the contradiction between a natural right to freedom and the fact of slavery. If whites were their own distinct category, then they could feel a lot better about denying freedom to people who they labeled black and decided were fundamentally different. But as political priorities change, definitions of race in America adjust right along with them. For example, if you were of Mexican birth or ancestry in the United States in 1929, you were considered white. Then the 1930 census changed that to non-white to limit immigration. Later, when the US needed to increase its labor force during World War II, these people were switched back to white. And what it took to be black once varied so wildly throughout the country, from 1/4 to 1/16 to the infamous 1 drop of African ancestry, that people could actually change races just by crossing state lines. Then suddenly in 2000, the government decided that Americans could be more than one race and added a multiracial category to the census. This has left many Americans scratching their heads when it comes to selecting who they are. As many as 6.2% of census respondents selected some other race in a 2010 survey. The idea that someone might look one way and identify another way, or that they might be really hard to place in a racial category, is not new. This is why there was a public debate about whether MSNBC's Karen Finney could say she was black, or how we can't even agree on the racial label assigned to the President of the United States. Of course, many people feel their racial identity is very clear and very permanent, but the fact that some people have changed theirs and that no one can really argue with them shows how shaky the very idea of race is. This is all because there isn't a race chromosome in our DNA that people can point to. It simply doesn't exist. When the medical community links race to health outcomes, it's really just using race as a substitute for other factors, such as where your ancestors came from, or the experiences of people who may have been put in the same racial group as you. Dorothy Roberts explains that sickle cell anemia is a prime example of this. The disease is linked to areas with high rates of malaria, which include some parts of Europe and Asia in addition to Africa. It's not actually about race at all.
Okay, so now we've gotten thinking about the construct with no biological basis. And I'm going to move into talking a little bit about what schizophrenia is, and then we're going to start to link these things together in terms of race and schizophrenia and psychosis. So schizophrenia is a diagnosis classified as a primary psychotic disorder. It manifests with symptoms in two main categories: positive symptoms, which include psychosis, delusions and hallucinations, disorganized thought, and disorganized behavior. And then negative symptoms, which are the 4 A's of schizophrenia: a flattening of affect, which means like less than emotional expression in the face; alogia, which is a lack of spontaneous speech production, some trouble finding words to say; anhedonia, which is the reduced ability to experience pleasure; and avolition, which is a lack of motivation. To be diagnosed with schizophrenia, you need at least 2 of these things, with at least one of them being one of those delusions, hallucinations, or disorganized thought, over a period of a month, and then with signs of these symptoms over a course of 6 months. So then let's move into like focusing on what psychosis means. When we think about psychosis, what do you think of these options as the most characteristic of a person experiencing psychosis? Would they be assaultive? Are they experiencing visual hallucinations? Are they experiencing disruptions in thought, making it difficult to recognize what is real? They usually have a history of poverty. So I'm seeing some people saying disruptions in thought, difficulty recognizing what is real, poverty. I don't know where my mouse is. There it is. Okay. A lot of people answering online are saying C. Okay, awesome. So yes, most of the people say, yeah, psychosis is a severe mental disorder in which thought and emotions are so impaired that contact is lost with external reality. And I usually like to kind of explain it as someone starts to lose the ability to really distinguish what is real from what is not real. When we think about the diagnosis of schizophrenia, it's actually relatively common, and then it comes with a really significant impact on the individual, their family, and also economically in the US. So 100,000 adolescents and young adults will experience a first episode of psychosis this year. And 1 in 3% of people develop a psychotic disorder in their lifetime. The diagnosis of schizophrenia comes with a reduced life expectancy by about 20 years, an increased risk of suicide, particularly in the early course of the illness, reduced quality of life. I think one thing to note here that really shows this is the very high prevalence of homelessness in people who have schizophrenia, family burden and distress, thinking about these families who are worried about their loved ones and may not even fully understand what they're going through or experiencing or why it's happening. And then to take on that wider lens of the economic burden, it's about $155 billion per year in the US. Relating this back to race, we know that today, for racial minority populations, there is overdiagnosis, misdiagnosis, and mismatches in treatment of schizophrenia. So racial minorities are much more likely to be diagnosed with schizophrenia. They are more likely to be diagnosed with schizophrenia over mood disorders like depression or bipolar. So that's that misdiagnosis piece. Overall, racial minorities are undertreated when it comes to mental illness. When they are treated for schizophrenia, they're much more likely to receive older medications at higher doses. So then the question becomes, why is this the case? A piece of the answer comes back to this systematic categorization of a normal response to collective trauma as pathological. This goes like all the way back to the beginning of our country, of the US. And there's so many historical examples along the way. I'm just going to point out a few today. And it all leads up to this fact that we know that racial minority status is a risk factor for psychosis. So going all the way back to like 1851, slavery, this physician, Sam Cartwright, he publishes a paper called The Report on Diseases and Physical Peculiarities of the Negro Race. It defined 2 diseases that he used to justify enslavement as a therapeutic necessity for Black people. This is what we call medical cloaking. So it's like disguising slavery as something because of some sort of medical issue or biological difference between Black and white people. One of the diseases he described was called drapetomania, or the runaway slave syndrome, which he said was cured by beating the devil out of them, and also suggested amputating toes. The other was dysesthesia ethiopica, which was defined by disobedience, insolence, and refusal to work. And it was treated by working a slave in the open air under the watch of a white man. When you think about the negative stereotypes that people have of Black people today, and some of the words that I just used to describe these diseases, you think about ideas like crazy, disobedient, lazy, and you see how these stereotypes have come all the way back through our history to the very beginning of things. Fast forward to the civil rights movement. Protesters were defined as violent, aggressive, and they were often called schizophrenic in efforts to marginalize them. Many were arrested, and then on evaluation in the prisons and jails, they were deemed to have psychiatric illness and sent to psychiatric institutions. This actually led to a dramatic shift in the demographics of patients with a diagnosis of schizophrenia. It went from being a disease of withdrawn white women to a disease of aggressive Black men. And thinking about this in the historical context of the 1950s moving into the 1960s and 70s, you can see how much the culture of the times is affecting these medical diagnoses. In the late 20th century, Nixon's declaration of a war on drugs led to an increase in the incarceration of minorities. This is despite the fact that minorities use and sell drugs at similar rates as white people. You can see here on this slide, the lifetime likelihood of imprisonment of a white man is 1 in 17, and of a Black man, it's 1 in 3. For white women, it's 1 in 111. And for Black women, it's 1 in 18. And then you see also that the likelihoods are much higher in Latino men and Latino women too, compared to white men and white women. So bringing this into those factors that may be leading to overdiagnosis, misdiagnosis, and mismatches in treatment. We see things like these known risk factors for psychosis, like social adversity and stress, discrimination, bullying, trauma, police victimization, incarceration. These are all known risk factors for psychosis, and these are all things that Black people are more at risk of given our history and the systems that are in place. Mistrust, suspiciousness, like distrust of police, distrust of people in positions of power, distrust of medical providers. It likely leads to behaviors during those encounters that may be interpreted as symptoms or signs of schizophrenia or psychosis. Things like evasiveness, guardedness, paranoia, and even aggression. Mismatches in treatment may also come from alternative pathways to treatment that minorities often take. Things like going first to trusted friends and community leaders, religious leaders, rather than directly to the healthcare system. And then racism. We know that Black patients are more likely to be perceived as violent compared to white patients. And so this certainly has an effect on the clinician who is making that diagnosis or completing an assessment. One interesting fact to consider, and it kind of like puts together all of these risk factors, is that there is a significantly increased risk of schizophrenia in second generation immigrants from developing and majority Black countries. And we think that this is likely a result of discrimination, language differences, unemployment, living alone, being separated from a parent at an early age. So I think someone had brought in like ACEs in the chat earlier, like all of these things need to be considered when we're thinking about a diagnosis and evaluating people for these diagnoses. One positive thing is we do know that ethnic identity is actually a strong protective factor against psychosis and schizophrenia. So really fostering those, that identity and relationships within communities can be very important. Okay, so this is one moment where I'm going to pause and ask you all to kind of reflect on some of the information that I've shared. And we can kind of debrief and ask some questions and have some discussion. Wow. Okay. Does anyone want to share any thoughts or questions? So rate of misdiagnosis, it really varies depending on the study that's done. There are several studies that have been done looking at those rates. And so I can provide them to you at the end of the presentation if you would like. I know that all of the studies have been done mostly in adults, so we don't know too much about kids and some of the clinical high risk that I'll talk about a little bit later. And yeah, and so yes, a Black person can be labeled as schizophrenic without having had hallucinations because some of the other like criteria for schizophrenia, one might be delusions. And so some of that paranoia may be easily misinterpreted as like a paranoid delusion, which could be interpreted as psychotic. And then also disorganized behavior. So if someone is acting like aggressive or an evaluator is not understanding where that behavior is coming from, that may also be interpreted as disorganization, which is also one of those criteria for schizophrenia. So the hallucinations don't necessarily have to be present. I'm just reading some of these questions. Okay.
While Olivia does, I just wanted to chime in one thing. People appropriately asked about, can't environmental factors be associated with schizophrenia or not? And here's the kind of interesting way that we tend to look at this. We know that if you look at it from the other direction, genetics, we know that about 50%, a little bit more than that, like 56% of people with monozygotic, when you look at monozygotic twins, so identical twins, they have the exact same genetic material. About half of those twins, even if they're raised in different places and completely different environments, will have schizophrenia. So yes, genetics is important, but that also means that half are not going to get it, even having the exact same genetic material. So the point is, clearly there's something else in the environment. It's not just genetics that results in people being vulnerable to and developing schizophrenia, at least. So it's clearly something that is influenced by environment.
Yes, absolutely. Someone mentioned like clergy, religious leaders accounting for mental health referrals in the Latin community. And yes, this is absolutely true of the Black community as well. So a lot of times we will go to some of those religious leaders, and it's great to do education with them as well, so that they have an idea of what to look out for when people come to them for help. Yeah, epigenetics is very interesting, how how the environment is affecting our genes. So awesome. Yeah, a lot of really good thoughts here. And I can definitely share some of the studies that I used to create this presentation at the end. So environmentally, are the symptoms coping skills? Oh, I'm not sure I understand that question. Laura, do you want to ask that? On audio? That's a good question too. So if environment may be a contributing factor, does a change in the environment reduce symptoms? Typically, what we know that once somebody has that first episode of psychosis and they're diagnosed with schizophrenia, those environmental factors have kind of played their role in terms of creating that first episode and then that onset of the disease, but certainly making the environment like less stressful would help with symptoms. Absolutely. Okay, I'm going to move on. So now that we've kind of talked about like the history, I'm going to start to talk a little bit more about the course of schizophrenia, what that looks like, and what we can do to think about like points of intervention and how we can make things more equal in that sense. So I'm going to use a case to kind of help describe, how this usually looks. There's 3 phases when we think about the course of schizophrenia. And I'm going to talk about, I'll just use a case, Sam, who is a 17-year-old boy. He's in high school. He has lots of friends. He's interested in arts, plans to apply to college soon. He's doing well. So Sam right now, he's in this pre-morbid phase. So that's this first phase. He doesn't have symptoms. He's doing well. As he starts out in art school, he's 18 years old. Sam does well in his classes, but he starts to have trouble distinguishing his dreams from what's real. He feels uneasy during his morning runs because he sees shadows and figures out of the corner of his eye. His friends have to ask him to repeat himself sometimes because what he says is a bit confusing. And they worry he's not going out as often as he used to. So this is kind of this risk syndrome. It's considered to be the first stage of illness. So as you can see, like under the arrow, the duration of illness starts here in this risk syndrome. And it's really characterized by these early warning symptoms and signs that are pretty non-specific. So things like feeling like something's not quite right, confusion or jumbled thoughts, trouble speaking clearly, unnecessary fear, being less interested in other people, activities, self-care. Sometimes we see what we call attenuated psychotic symptoms. So those are like very mild delusions or hallucinations that the person can still distinguish are not real, and functioning is still okay. Now fast forward to Sam's junior year of college. He starts to believe that his professors are working with the federal government to monitor and follow him. They've implanted a chip into his brain to hear his thoughts and control his actions. He stops going to classes and spends all of his time researching ways to evade the feds. So this is what we would call like the first episode of psychosis. At this point, our patient cannot really distinguish which of his thoughts are real and which of his thoughts are just thoughts and they're not real. And so that's where that first episode of psychosis starts. Now you can see that from the time that that first episode starts and the time that people are treated, there's a lag time there. And we call that the duration of untreated psychosis. We know that the longer the duration of untreated psychosis, the worse the outcomes are. With longer duration of untreated psychosis, we see increased negative symptoms. That's like the flattening of affect, alogia, anhedonia, and avolition. There's more social impairment and occupational impairment. There's a higher need for more intensive services. So that's like hospitalizations or assertive community treatment teams, more neuropsychiatric deficits, and also just increased psychological distress. So what we want to do is identify these people and engage them through the healthcare system early so that we can have better long-term outcomes, decreased overall distress and burden for patients and families. That economic burden we talked about earlier, decreased economic burden because people aren't utilizing these like really high intensity services if things are identified early and managed early. The important thing with this is that it has to be implemented with the right tools. And that also includes active community involvement, recognition of biases, cultural and contextual factors, and understanding this history that's created our systemically marginalizing mental health care system. So a big area of focus has been this clinical high risk syndrome, which is a syndrome of subthreshold symptoms, that risk syndrome that I was talking about earlier. And we want to identify this early to improve those long-term outcomes. We know that people who are experiencing this are about 10 to 40% of them will go on to develop psychosis. And then even that majority who do not often still have relatively poor functioning. So this is a good group to identify. We see like a lot of these negative symptoms here, like cognitive difficulties, withdrawal from friends, family, trouble with motivation, trouble thinking and communicating clearly, that emotional flatness, feelings of suspiciousness, mistrust, or something's not quite right. And then we do see often a deterioration in functioning in this clinical high risk syndrome. And then there's this group of people that are also defined as ultra high risk. So these are people who have attenuated psychotic symptoms. So those are those like mild delusions and hallucinations with intact reality testing. A genetic risk, so it's like a family history of schizophrenia or bipolar disorder, and with a functional decline, and then periods of brief intermittent psychosis. So these are periods of psychosis that typically last less than a week. How do we identify this clinical high risk state? The gold standard is a diagnostic interview called the SIPS. So this is the structured interview for psychosis syndrome. It's a great way to identify clinical high risk, but it's also lengthy and it requires a specialist to administer. So it's a bit difficult to use in a broader sense. There's also these shorter self-report screens like the PRIME screen, the YPARC-B and the PQ-B. And then also this 2-item screen that I found with just these 2 questions. Do you ever hear the voice of someone talking that other people cannot hear? And have you ever felt that someone was playing with your mind? If these questions are answered positively, there's a 71% chance that you've identified somebody with clinical high risk. The good thing about the screens is that they're brief and they can be used broadly. The backside to that is that they don't really take into account the context, the person's culture, or other factors that may be affecting the validity of the screen. So it's important to know that this is just a screen and not a diagnostic tool. All right, let's take a moment to ask some more questions. And I think people have been putting stuff in the chat, so I can take a look at that too. Yeah, so one of the questions was, with the early intervention, do people experience better adherence to medication management and treatment? And the answer to that is yes, because we're intervening early, we're able to really better educate not only the patient, but their family and whoever their supports are. And that creates a much better environment for treatment adherence. And then we're also limiting the number of like decompensated psychotic episodes that are happening. And we know that with each of those episodes that happens, there's a further decline in functioning. So we want to limit that from happening as much as possible. And so the earlier we can intervene, we know that that brain is going to be protected and have better outcomes in the longer term. How are minorities supposed to pay for these evaluations and treatments if they have no insurance? That's a good question. We're going to get to some of that too, in terms of like what we can do to advocate for better access to mental health care, because that's a huge issue. And that's something that's very, very important. We want everyone to be able to have access to not only someone who's going to screen for these things, but also someone who's going to follow people who are identified as high risk and also treat whatever needs to be treated. Somebody asked about brain development. The really interesting thing about schizophrenia is we know that the causes of schizophrenia, there's not one clear cause, and that it's really multifactorial. So like Dr. Bostic mentioned, we know that there is some genetic component. There's also an environmental component, and all of that is affecting, yes, the development of the brain, and some of it is the environment, some of it is the genetics, and that's what we're not 100% sure how, why one person ends up with schizophrenia versus not somebody else. And that's where a lot of research is focused as well. So if reality testing is intact, they can still be considered at risk. For example, if they think their imaginary friends are real and they're in their early 20s. Yes, so so these like mild attenuated psychotic symptoms, or having had any experience with psychosis in your life, is actually really common, particularly in young kids. A lot of young kids, like you mentioned, have like imaginary friends. At the same time, we know that people who have those experiences are more at risk for developing a primary psychotic disorder later in their life. So it's something to kind of like to normalize, but also to take note of if there's other things that are concerning, like some of this like withdrawal or functional decline, or like cognitive issues like that, getting words jumbled up or not, having confusing thoughts, that kind of stuff. Okay, I'm going to move on so we can talk a little bit about what we can do. What can we do about disparities in diagnosis and treatment of schizophrenia? Kind of like the first building block of this that everyone can do is to work on cultural competence. So understanding your own culture, but also being open to learning about other cultural practices and worldviews, and having a positive attitude towards those cultural differences, a readiness to accept and respect those differences. For clinicians, one of the really nice tools that we have is this cultural formulation interview. It's very patient-centered. It prompts clinicians to ask questions that elicit the patient's perception of what the problem is, how their community has responded to them and responded to the problem, how their cultural identity plays a role, what's been done, what they have been done to cope or seek help, what their expectations for treatment might be, and what their needs and preferences are. This is a really good way to be very culturally aware and culturally sensitive in evaluating somebody. Relating to psychosis, we just want to be really mindful of cultural context and bias. So there's a lot of these questions on the screens that I mentioned about suspiciousness and paranoid thoughts. They're much more likely to be answered positively by minority populations. And we think this is related to somewhat to that higher risk of those people having or living in like dangerous neighborhoods or being exposed to community violence or, things like that, where it is normal to be maybe more suspicious or feel unsafe at certain times. This mistrust in the historical context and how that might come off as somebody who's more guarded or withdrawn. And then the interviewer bias. So that's that, how are we perceiving this person, and to recognize our own biases. The next step would be to work on like education. So intentionally adding to our knowledge on the subject and then sharing what we learn with others in our community. So this is a part of that. And hopefully you take whatever you learn here and share that with your own communities as well. And so this is just sharing that information and helping to keep everyone aware of the biases that exist. And then this leads us into like, okay, how do we act even further? Let's advocate for improved access to care and modification of mental health systems to reduce bias. How do we do this? We can advocate for screening to identify those at risk of developing psychiatric disorders, integrating mental health into schools and primary care practices. This is a really great way to increase access to mental health care. And then educating our communities about mental health. And then on that like broader level, also working to improve systems that increase those psychosis risk factors in minority populations. So this is getting all the way back to like that root of the problems, things like addressing poverty, discrimination, trauma, and police victimization. So advocating to improve these symptoms and allow more people to have, that equity in terms of the way that they're living their lives. Okay. So we're almost done. What are some people's thoughts? Yeah, I see a lot of people talking about like ACEs and toxic stress. Yes, the same evaluations are used for minorities and white people. I think right now the guideline is just to be culturally aware and to understand that some of those questions about paranoia or suspiciousness can be, not always valid. I see Ms. Sherry Key saying we should also consider how funding from the NIH is distributed for research about minority populations. Asian Americans are only allotted 17% of the funding. We should avoid use of aggregate data when providing research models to the public. How can you call into account when a clinician is using bias in providing testing and assessment? That's a good question. Is there a good way to screen out dissociative disorders from non-affective psychosis? I don't know about screening out. I think that has a lot to do with more like the diagnostic interview and really getting a good sense of what's going on. Okay. Well, I hope that you all learned something today. I know we only have a few minutes left. I think some of the key takeaways here that our history has set up minorities for increased risk for psychosis. That early identification of clinical high-risk state can improve outcomes in schizophrenia. And by working towards cultural competence, education, and advocacy, we can change our systems to be less biased. Oh, what happened? Okay. And more effective in supporting our communities. So thank you so much for participating and for being here with me.
Yes, Dr. Bossi, just to say thank you for attending. I did want to back up to one thing. Several of you asked really good questions at the end about how do you call out a clinician who is seemingly not recognizing possible structural factors such as racism that are influencing their evaluations and then their judgments about diagnosis and perhaps inflating the numbers here in directions that are inaccurate. So the big thing is, of course, we're trying to do some of this through awareness. But again, you out there more than anybody are the most helpful people for recognizing, identifying, and helping certainly advocate, as Dr. Hammer said here, for people. And that means families and kids and everyone else to like look up, and when they see something that doesn't sound right to them, when they feel like a clinician may not be taking into account reasons that a person might appropriately feel, our example all ago is paranoid or whatnot, that's actually not necessarily consistent with the rest of symptoms that they have that are not suggestive of psychosis, and therefore to diagnose them with schizophrenia, for example, just doesn't really fit. It's not parsimonious. So taking apart the constellation of symptoms that people have can be very helpful for better discerning if something truly fits over here in the psychosis category, or you have reasons to be cautious, thoughtful, and whatnot about these things. So I think these are really good questions, and trying to equip kids and families with ways to speak with their clinicians when things don't really seem to add up correctly, where it's a simple kind of process where someone ticks the boxes, meaning the clinician here. I think that's appropriate. So that's really an important question that you guys have brought up. So thank you. Back to my role here, I just want to say, please, you're going to get an email. Please just take a minute and say, this was helpful. We'd like more on this or something different on that. It's very helpful for us as we're plotting out stuff here for the future. So thank you so much for responding to that when you do. And yes, recommending second opinions, I see in the chat box too. If it doesn't add up, you should absolutely feel encouraged to do that, of course, always, particularly if you have clinicians that are in your vicinity that you can access, that you feel like may be more culturally attuned to that family and better understand that family, or feel more trusted by that family. It absolutely does make a difference and help. And then finally, shifting back gears here, please know that you can reach out to the NTAC at any time. We're here again for systems of care, components for anything that will help advance the care of children, youth, and families. So please reach out for anything that you need. A bunch of different ways here that you can do this. And yes, this presentation was recorded, so you will be able to access it through that website further on. So again, thank you so much for attending today. We're most grateful.
Thank you so much.